So today, I don't have a lot of time, so I'm going to briefly cover the background of our EIDM process to develop a report, which the link is actually in the back, the very last slide, which is a review of the evidence, school-based interventions to address obesity prevention in children 6 to 12 years of age. So if you're interested in looking at the report, you can access it. We've put it on the Health Evidence website. I'm going to then highlight the report recommendations, again, pretty quickly, and then discuss the steps that we've taken since developing the report in integrating the evidence into what we actually do at Toronto Public Health. I'll premise it by saying we're also very early stages, so it's kind of real time right now in terms of some of the things that we're doing. So I'll talk about what stage we're at and then some of the things that we're going to be doing in terms of deliverables in the future. So hopefully you can glean some information out of our process so far. And this is just some of the things I'm going to be talking about. So Maureen already covered the stages of evidence-informed decision-making. We actually were very fortunate to be part of a project through Health Evidence. And we worked with Cara DeCorby, who's a staff person at Health Evidence. And so basically, we used the EIDM process to integrate the best available research evidence into our decision-making process at Toronto Public Health, and as it relates to obesity prevention. So to give you a bit of background, a lot of, during that summer when we were kind of refining and having discussions around the type of research we wanted to do, there were a lot of, well, there has been for many years, I guess, a lot of research out there and a lot of reports being released around childhood obesity as the rates rise. But at that time, there were a number of things coming out, the F grading for the Healthy Active Kids report card. There was also, many reports. There was also the Institute of Medicine. They released their report on accelerating progress in obesity prevention. And one of their critical environments for change that they had identified was schools. There was also Deb Matthews, who is our health minister in Ontario, and she created a Healthy Kids panel that's been doing a lot of stakeholder engagement, asking for information. They also did a survey. They were supposed to come out with something at the end of the year. We haven't seen anything yet, and we've actually did give them our report as well. So we'll see what comes forward from that panel. And also we're having some internal discussions around what we were going to do or what we were going to look at in terms of our research. And as Maureen was saying, we look beyond kind of the EIDM model is kind of beyond just the research, so we also have to kind of look at the local context and so on. So we were having a lot of discussions at that point. We were also familiar with the Waters Review that came out that was very strongly in favor of school-based interventions. And we know that we're more successful preventing obesity versus reversing it. So we originally were looking at doing something within the general population, which was really broad. And so we had these internal discussions based on kind of what was happening and basically decided we were actually going to focus in on school-based initiatives with children ages 6 to 12. And we really thought that with doing this report, it would be better for us to focus in so we could really have some usable recommendations in the end. So our PICO question was, what school-based programs are effective in low-income communities' neighborhoods to address risk factors related to obesity in children ages 6 to 12? And we did want to look at low-income communities and neighborhoods. So earlier when we were talking about relevance criteria, so we were pretty clear on what we wanted to pull from the evidence. So whereas Philip mentioned a bunch of different reports, some of those are systematic reviews that we looked at. Some of them got screened out for us because if they did not have any results related to some of these communities, then they ended up being screened out for us. And again, that's why it's really important to be as specific as possible if you're looking at specific relevance criteria. The search, appraise, and synthesis phase we went through, and we ended up with about 5 high-quality systematic reviews and 4 moderate-quality systematic reviews. We searched for the last 5 years. So anything before that did not end up in our review. We were really lucky that all of the 9 systematic reviews were already appraised through health evidence, which was great. We actually went through some of them, and we had some questions on some of the ratings, actually, and I think a few things got changed. So I think health evidence is really also open to having discussions with people doing work in this area. And then we found 2 guidelines as well. So the NICE guidelines, the National Institute of Health and Clinical Excellence, their obesity prevention, identification, and management guidelines. We looked at those. And also CDC had some school health guidelines to promote healthy eating and physical activity. And for guidelines, we had to use an agree-to tool, which I'm not going to get into right now, but it's not the most fun tool to use, especially when you're looking at the NICE guidelines that were 2,000 pages or something like that. So we really had to kind of really search for some of those answers. But actually somebody from Durham approached me earlier and said, I'd really like to see what your rating was through the tool that you were using, and that they actually contacted CDC to clarify some of the answers. So that's a really good thing to do too. And I know Kara actually searched out a little bit to see if the CDC and NICE reports had already been appraised. So that really helps. So basically, in the end, we looked at the results from 410 articles describing 364 separate interventions, because there were a number of interventions, obviously, in each of the systematic reviews and guidelines. And then we extracted data, the whole process, and then we categorized the results in these categories. Physical health status measures, as we were talking about earlier, you really have to kind of look at what the systematic reviews are saying in terms of outcomes. And you'll see when I get to the recommendations, you really have to read them very carefully, because each of them are related to a specific outcome. It's more complex that way, because I know even when we were writing them, we were like, oh, is this the same as, no, we're looking at a different outcome. But it's really helping us now as we move forward to be that specific in terms of outcome. So physical health status measures is anthropometric measures, waist circumference, BMI, that kind of stuff. Physical activity measures, physical activity rates, sedentary behaviors, steps counts, that kind of stuff. Dietary measures, food and nutrition intake, and dietary behaviors. And then psychosocial, psychoeducational measures, which are knowledge, attitudes, preferences, well-being, self-esteem, those types of things. So in order to formulate our recommendations, we basically looked at what worked and didn't work in all the systematic reviews, and we identified themes so that we could compare what we were finding and what we were seeing in the systematic reviews. So I mentioned earlier that a lot of the systematic reviews reported out by outcomes, so we made sure we identified specific outcomes in the recommendations. Just to premise the recommendations before I go through them, you'll recognize a lot of these things too, right? Because often a systematic review will reinforce what we're already doing, which is actually a great thing. And it's always a good thing to do and to go back. And because we were only looking at the last 5 years, we have the most current evidence. And it's validating sometimes to see that we are on the right track. And then sometimes doing this type of exercise for us is also good, because then we can step back and go through the recommendations and say, okay, this is what we're already doing. Where are those gaps and opportunities? What are we not doing so well? And what are we not doing at all? So as I mentioned, there's different themes. So this slide highlights the setting and audience. Pretty no-brainer stuff on this slide, just around that we should implement obesity prevention interventions in the school setting, targeting children 6 to 12, mixed gender groups. This was a significant finding for us. Again, remember when I mentioned earlier, our relevance criteria was looking, though, at low SES, and that we should be implementing obesity prevention interventions in schools in lower socioeconomic neighborhoods to increase physical activity levels and improve dietary intake. And then TPH should implement obesity prevention interventions that target all children versus just children that are already overweight or obese. So the next theme was dietary-based interventions. We just have 4 recommendations related to that. The first one is, well, let me premise this by saying these overall recommendations highlight the limitations of using anthropometric measures only as an outcome indicator. when engaging in dietary-based interventions. And it also highlights our ongoing approach at Toronto Public Health to focus on behavior change related to physical activity and diet, because we know that health benefits are achieved regardless of BMI when we're doing our programming. So the first recommendation is that we should not be implementing dietary-based interventions alone to improve anthropometric measures. And I've highlighted all the outcomes there so that we don't get confused between them. And then TPH should implement dietary-based interventions to improve dietary intake and/or behavior versus anthropometric measures alone. So overall, no impact on anthropometric measures, but you'll see later when I speak to multi-risk interventions, then there's not only an impact on anthropometric measures, but there's also an impact on the physical and dietary behaviors. Third one, TPH should implement environmental or policy-based interventions such as breakfast and/or fruit and vegetable distribution programs to improve dietary intake. And TPH should not implement environmental or policy-based interventions focusing on system-wide nutritional change to improve anthropometric measures. So things like our student nutrition programs definitely can improve dietary intake either alone or part of a multi-component intervention, which I do have a theme around multi-component, you'll see later. But doing environmental or policy-based interventions that focus on those changes solely to change the anthropometric measures, we didn't find was useful. Physical activity-based interventions, I think I have about 3 slides. So the first one, TPH should implement physical activity-based interventions that decrease sedentary behaviors to improve anthropometric measures. The next one is implementing physical activity-based interventions that focus on extended physical education classes and activity breaks to improve anthropometric measures. And then I'm going to skip to the fourth one. TPH should implement physical activity-based interventions to increase physical activity measures. So basically that last recommendation relates back to the first 2 recommendations, but remember, it highlights a different outcome. The outcome for the first two was around anthropometric measures. The last one is related to increasing physical activity. So that's really interesting to see the both there. And then the third one is TPH should not implement physical activity-based interventions involving fitness enhancement to improve anthropometric measures. And some people might kind of go, what? We're not saying that fitness enhancement is not important, because we know that maintaining a level of fitness can counter some of the obesity-related health risks of weight gain over time. But in terms of, again, the outcome to improve anthropometric measures, we found that it was not recommended. So more physical activity, TPH should not implement physical activity curriculum alone to increase physical activity levels. This is probably obvious. And then TPH should implement environmental or policy-based interventions to increase physical activity levels. So again, just like earlier, the earlier recommendation around dietary interventions, they're saying physical activity, the outcomes can be altered based on environmental or policy-based interventions. Multi-risk approach. So we have a recommendation around implementing a combination of physical activity and dietary-based interventions to improve anthropometric measures, as well as physical and dietary behaviors, as I did highlight this earlier. So we know that by implementing an intervention that is multi-component, we can actually impact on all of those outcomes. Multi-component approach. So this is looking at, I know there's the multi-risk, but multi-component is basically those behavioral, environmental, and educational components. So like health education, enhanced physical education, and promotion of healthy food options. So just a variety of those components. And then do not implement either physical activity or dietary-based intervention or education in isolation. And the last two slides, I think, of recommendations relate to just kind of other intervention components. That we should include psychosocial, psychoeducational components. I mentioned that earlier around self-esteem, well-being, knowledge, attitudes, and preferences, lasting at least 3 months. We put at least 3 months, but I mean, we would really like to say a lot more than that, but at least 3 months. And then the family component is again, something we already know. But what we found was kind of interesting was, but if you're going to do a parental component, you really should do a high level of parental component or involvement, which includes a behavior change goal for parents as well. Peer leaders, we found useful incentives, obviously partnering with school staff and intervention specialists. And then the last recommendation it was a bit of concern that only a few studies in the selected systematic reviews actually examined these effects, the harm or unintended effects. So overall, we kind of thought, you know what, let's just put an overall recommendation that we should be addressing these effects when planning, implementing, and evaluating obesity prevention interventions. So once we completed the report and made our recommendations, what were our next steps? As Maureen was mentioning earlier, we don't want to just kind of do the report, put it on the shelf, say, you know, we've done some research on this. Let's actually take it to the next level and figure out what we're going to do about it. We obviously want to change our programming based on it. So we did meet with all our chronic disease and injury prevention managers, as well as our director, presented the results of the report, had some discussion, and then our director basically said, let's form a work group, and we need a separate work group because we need them to focus really on this. So we have a number of members on this group. So one of our first steps was to actually, in your package, you do have the applicability and transferability tool. And that was kind of our first discussion. We're going to be actually using this tool, I would say, as a touchstone to kind of go back and forth, because when you look at the question, it's very specific related to the intervention. And at that stage, when we had our discussion, we had an idea of components because we had a list of recommendations. We all have the experience around the table related to kind of what we do and what Toronto Public Health does. So we went through the tool kind of at a higher level. And just to say, if you're looking at the tool, there's actually two different versions. There's one when you're starting a new program, and there's one when you're stopping an existing program. So we actually looked at the starting a new program piece. So this also goes back to the discussion related to the EIDM model, because the research piece is only one part of it. There's obviously looking at the context and all the things that are kind of happening that all meld in together in terms of what will direct your programming and your future actions. So we had some discussions around, you know, political acceptability or influence. We kind of looked at, you know, the federal level where, you know, in 2010 there was a framework for action around healthy weights. In 2011 they're doing this national dialogue, that kind of stuff. Provincially, I mentioned the Healthy Kids panel that's come about. Well, I guess it maybe even it started a lot earlier than that with Sheila Bazur's report in 2004, who was our Chief Medical Officer of Health at the time. And then, you know, the after-school strategy funding, the inklings of maybe childhood obesity funding, OMA, the Ontario Medical Association, they had a lot of media attention around their junk food tax and wanting to put graphics on containers of junk food and stuff. Local level, we know within Toronto Public Health it's a high priority. And it does tie well to some of our diabetes work that we've been doing around our diabetes strategy. But we also have to recognize that there's some labor disruption happening within our Toronto District School Board. So if we're looking at schools, we're also internally doing a student health survey, which actually has been delayed. So we have to keep that in mind in terms of timelines. There's a lot of other, you know, kind of things that obviously we had discussions around. And then also around the social acceptability of this issue, and the need to be careful about how you position initiative in this way, because of the risk of stigmatization and that kind of stuff. So, and then available essential resources. We, you know, discussed potential cost requirements and shifting of resources. That would definitely have an impact on other programming that we have. Organizational expertise and capacity. You know, it does sit well with our strategic and operational plans as well as some of our local priorities. And then some discussion around transferability or generalizability. We know, you know, the need exists. We know even though Toronto is an urban center and our rates tend to be lower than some other areas in Canada, we do have pockets that are actually quite high. And we work within 8 service delivery areas, and we do have one in particular from our surveillance data, that the rates are quite high. So, guiding principles. So our work group developed these guiding principles, and we definitely want to use the best available evidence. Build on current programs while incorporating innovative approaches. We really want to recognize the fact that we do have a lot of great programming already too. And then integrate a positive mental health and well-being component, address the harm or unintended effects, and then ensure that approaches align with our existing frameworks. We have practice frameworks, we have access and equity policy. We actually have a discussion document around how we approach promoting healthy weights. And so on. Our first deliverable was to identify gaps and opportunities. So what we did was we first kind of looked at, I'm going to call them critical success factors, in terms of what would we see in an intervention if we were to kind of build this straw dog type of thing. And from the literature and then from the expertise around the table, we took those kind of critical success factors and we put them in our 4 pillars of our framework for healthy schools, which is high quality instruction programs, a healthy physical environment, a supportive social environment, and community partnerships. So once we had those in there, then we kind of compared, and really some of those gaps and opportunities were kind of starting to solidify, and we're starting to see that around, you know, some of those things that have been kind of highlighted is around family components. Not, you know, that's something we're not doing very well in. Peer leadership doing more, but we've actually just developed a peer leadership framework, so using that more. Physical literacy, screen time in school age. We have an initiative around early years, but not school age. Increasing opportunities for unstructured play, active transportation, just some of the things I just kind of pulled out. They're not totally inclusive, but. And then we will, so now we're at the stage of trying to develop this kind of comprehensive model, like what are we going to see here? So now that we've kind of identified these critical factors, we're going to go back to some of those programs that we saw. This is when it gets to the kind of really nitty-gritty, that we saw across some of the systematic reviews that really had positive outcomes, and go back and actually see what they were actually doing. That's the, I guess, part of the problem of doing a report like that. When you have high-level recommendations, you don't really know exactly how they did that, right? And so we're going to try to find that. We've kind of developed some questions to go through, and people have taken away that information or that task. And then if we identify that there are some missing components, and that's the time to really maybe potentially have to pull some single studies, and then even start thinking about innovation. What could we actually do? If it's not in the literature and it hasn't been evaluated, what could we do? And then we'll be doing some of these other things, identify other internal, external partners, potential roles, all that kind of stuff. So just quickly in terms of our reflections around successes or kind of the facilitators of the process so far. Our director, MOH, management support, again, I mentioned having the master's student, and then a lot of all the staff on the working group have, you know, a lot of expertise, strong relationships with the school board staff. I was just thinking when I was reading this, like last night, I thought, geez, you know, we also have, you know, some existing programs that we deliver in the schools that are really good. That's another, you know, facilitator or success. And also remembering that the school, we have a real mutual kind of goal to increase academic performance. So sometimes you have to kind of go in that route when you're working with the schools to get that commitment. And then barriers. I mentioned how much time required to do a full report. Lack of evidence in Canada regarding what works. We actually, one of the programs we're looking at was not even in our systematic review because we came across it and there's some preliminary evaluation stuff. So we're actually going to go delve deeper and see what they did in their intervention. No additional funding, we don't know. We're in the midst of trying to figure out. At council, we lost by 1 vote to get a big chunk of money, unfortunately, but we're still internally trying to secure some additional funding or maybe find a research partner as well. But we're going to do what we can do internally for the time being. Competing demands on staff time and then need to rescope staff assignments. And I also threw down, I mentioned earlier, labor disruption within school boards, and then also the schools having competing demands of their time because everybody's going to them. So I think on that note, I'll end there. And so I thank you very much. And there is the link to the report if you're interested. And if you have any questions and you want to contact me too, my contact information is there. Thank you very much.